Start.
Yes. Good morning, everyone. Today, the topic of my presentation is disorders of emotion. My moderator is Dr. Shobit sir. Now, in this presentation, I'll be going through various headings under which I'll be covering some definitions and theories regarding emotions, basic emotions, communication of mood, and then the disorders of emotions. Now, some definitions. Feelings. What is a feeling? A feeling is a positive or a negative reaction to some experience or to some event, and it is the subjective or experiential aspect of emotion. Emotions are a stirred up state which are caused by physiological changes occurring as a response to an event, which tends to maintain or abolish the causative event. Now, mood is a pervasive and sustained emotion that colors the person's perspective of the world. Now, what is affect? Affect is a short-lived emotion. It is the patient's present emotional responsiveness. That is what a doctor infers from a patient's body language and the facial expressions. Now, affect can be assessed by two parameters that can be subjective or objective. Now, subjective can be, we can ask the patient, how do you feel? And objective is, it is based on the observation of the interviewer. Affect is assessed under these parameters. Under these parameters, which include the quality, intensity, mobility, range, reactivity, communicability, appropriateness, and diurnal variation. Now, the quality of affect, it can be dysphoric. That is an affect which is characterized by emotional states such as sadness or anxious. That is a very unpleasant feeling in which the patient has a feeling of apprehension that something terrible is going to happen without knowing what. Irritable, that is a sense of poor control over the aggressive impulses, and it is mainly directed to the near and dear ones, and a patient is very prone to get annoyed easily and provoked. Now, depressed is it is an affect which is tending towards sorrow. There is diminished muscular tone and weeping. Elevated is an exaggerated sense of well-being. Euphoria is an increased sense of well-being with cheerful thoughts and lack of response to depressing influences. Elated is euphoria with increased psychomotor activities. Exalted is elation plus sense of grandiosity, and ecstatic is an sense of blissfulness. Euthymic refers to normal mood. Now, the intensity of affect, it is basically the strength of emotions, which can be shallow, which lacks the depth of emotions. It can be blunted, that is, a patient has an expressionless face or a uniform voice no matter what the topic of the conversation is. Now, flat is an absent affect. Now, mobility is the ease and speed with which a patient changes from one emotion to another, which can be decreased mobility as in constricted and increased mobility as in mobile, wherein the patient shifts very rapidly from one emotion to another, or fixed. Now, the range of emotion refers to the variety of emotions which a patient presents in one session, which can be full range or it can be a restricted range. Now, reactivity, it is the fluctuations in effect which occur in parallel to one's environment, which can be non-reactive or reactive. Communicability is the capacity with which the patient interacts with the interviewer, which can be present or absent. Now, appropriateness, it is the congruence between the expressed quality of emotions and the content of speech, thought, the expected degree of intensity, which is appropriateness includes paramenia and parathymia. Paramenia, it is the lack of unity between various modes of expression, and parathymia is the expression of emotion that is exactly opposite. What is expected under these circumstances, for example, laughing at a tragic news. Now, there can be a diurnal variation in effect also. For example, morbid depression, it is worse in morning, and delirium is worse in evening. Now, according to Ekman and Friesen, we have 6 basic emotions, which include happiness, sadness, anger, fear, surprise, and disgust. Now, these basic emotions, these are universal, but they can also vary in terms of culture. For example, in one culture, where a food is considered as a delicacy, but in another culture, the same food may be revolting. Now, theories of emotion. I have described 3 theories of emotion here. The first one is the James Lange theory of emotion, which was developed by William James and Carl Lange. Now, according to this theory, there is a physical stimulus. For example, here there's a growling dog. Now, to this growling dog, there's a physiological response, that is our sympathetic system would get activated, and to this physiological arousal, there would be emotion. Now, there was this theory was criticized in the sense that the physiological changes, the visceral responses to stimuli are too slow to account for the rapidity of emotions that arise in the presence of appropriate stimulus. Now, the second theory which came up was the Cannon-Barth theory of emotion. According to this theory, for example, when we see a growling dog, so first of all, we have an emotion that is a fear of, that is a subjective experience of fear, and which leads to the physiological arousal. For example, our heart pounds. Another theory was the Shaster-Singer's theory. It is also known as the two-factor theory of emotion. It says that emotion comes from a combination of state of arousal and a cognition that makes best sense of the situation the person is in. For example, when we are in a social context, we are and there's a physical stimulus. So we respond to that physical stimulus by some physiological arousal. Now, in response to that physical stimulus, the social context, it can be apprehensive to us or threatening to us. So we would feel fear, and if the social context is happy or funny, then the cognition would be that the emotion would be a positive one. Now, communication of mood. Our feelings are affected by those around us. They're observable and understandable to other people as a non-verbal message. Now, in communication of mood, the most important discovery in the decade, which was the most hyped topic, was the mirror neurons. Now, these mirror neurons were discovered in the 1980s by Giacomo Rizzolatti and his colleagues in the Mickey monkeys. They found some neurons in the prefrontal cortex of these monkeys. Now, these neurons fired when an animal performed a motor action, and also when an animal observes the same action being performed by another animal. So basically, these neurons mirror the behavior of another animal. In humans, the relevant neurons are found in the premotor cortex and the inferior parietal cortex. These neurons are important for imitative learning, for empathy, and the capacity to understand another person's emotional state. Now, we come to disorders of emotions. Under disorders of emotions, we'll be going through normal and abnormal emotional reactions, abnormal and morbid expressions of emotions, and morbid disorders of emotions. Now, this terminology and this description of emotions and the classification, it is a bit confusing, because the same terminology may be used to describe the appropriate and the normal emotions, and the same terminology would also be used to describe to what we consider as pathological, which may even warrant hospitalization. So here there's a linguistic confusion, and it is quite difficult to distinguish the normal from the abnormal emotional reaction. Now, what are normal emotional reactions? These are normal responses to events. For example, a grief reaction that follows the death of a loved one, or a response of a previously healthy person to a life-threatening diagnosis. So a person exhibiting a normal reaction to a stressful event is unlikely to be incapacitated from carrying out their normal duties for other than the briefest periods of time. Now, if these normal reactions, these are associated with more prolonged impairment in functioning, we call them as abnormal emotional reaction. Now, here we can see a curve which is known as the Yerkes-Dodson curve. As per this curve, there is a level of stress, and when that level of stress it rises, there is healthy tension, motivation, and we get more focused. But at the peak, when the stress levels get too high, fatigue sets in, and then there is exhaustion, panic, and anxiety, anger, burnout, and breakdown. Now, this level from which we can differentiate the normal and abnormal reaction, it is attributed by the severity of the stressors, or the time for what the stressor was present, or the social support a person gets. Now, anxiety. Anxiety is an unpleasant affective state. That is, there is fear for no adequate reason. A person may describe anxiety in terms of tension, stress, and taut like a wire. And anxiety may even be accompanied by physical symptoms such as palpitations, sweating, breathing difficulties, etc. When these physical symptoms, these are accompanied, these are clubbed with feelings of impending doom or an overwhelming fear, then we call it as a panic attack. Now, there's a term which is known as anxious foreboding. That is fear that something terrible will happen, but without knowing what. Now, phobias. Phobias are a fear which is restricted to one object, situation, or ideas. Now, most fears, these are learned responses. For example, a person who develops fear of dogs after being bitten. Some phobias are secondary to morbid state, for example, depressive illness or fear of contamination, which are regarded as obsessional symptoms. Now, depression. Depression is the most commonly experienced abnormal reaction. Now, depression can be a symptom which is secondary to another morbid process. It can be an understandable reaction or it can be an illness in itself. Demoralization, it is seen in cancer patients and patients having serious physical and psychiatric illnesses. It is characterized by feelings of isolation, despair, discouragement, and helplessness. An individual feels trapped and is unable to plan or initiate action towards a specific goal. Anhedonia and guilt are absent, and an uncertainty about one's future direction is prominent, but motivation remains intact. Now we'll be covering abnormal and morbid expressions of emotions. Abnormal expressions are the expressions which are different from the normal, but the patient is aware of the abnormality. In this, the most important thing is dissociation of affect, which is seen in depressed patients. When some patients, they fail to exhibit an emotion where it would be expected, it is known as dissociation of affect. It is an unconscious defense against the impact of overwhelming stress or a feeling of numbness. Derealization or depersonalization. It is not a primary disorder of emotion, but a disorder of experience of self. It is associated with a feeling of being cut off or a feeling that some objects seem distant. David Livingstone, the explorer, described the feeling he had on being seized by a lion. It caused a sense of dreaminess in which there was no sense of pain or terror, although he knew what was happening. Now, the term belay indifference. It is usually seen in conversion disorders. The patients are undisturbed by their very severe symptoms and their suffering. Emotional indifference is seen in violent criminals who are able to discuss their unpleasant crimes without any emotions. Now, another very important term here is a smiling depressive. That is a patient who is basically a depressive. A patient with depression may retain the communicatory smile but will lose the emotional element. So although he'll be able to smile, the eyes will remain unchanged and there would be a display of tension in the surrounding muscles. This is a severe feature of depression and can lead to underestimating of depth of depression. For example, in this picture, we can see this one. This one is the genuine smile, which is known as the Duchenne smile. It typically engages multiple facial muscles and there is wrinkling around the eyes, the result of spontaneous joy. But in this picture, there is a forced smile. There is a curve of mouth, but the eyes, near the eyes, there is no wrinkling or there is no facial muscle engagement. Now, denial. Denial is a defense that may manifest as a lack of emotion. It occurs when a person denies awareness of an event, even though such an event has clearly taken place. There is a refusal to acknowledge what is true. For example, a loved one has a serious illness, a patient may deny the presence of that. Apathy. Apathy is emotional indifference, and often associated with a sense of futility. It is seen in prisoners, in schizophrenia, damage to frontal lobe, and it may result in self-neglect, inability to engage in daily activities, and social disengagement. Perplexity is a tentative or bewildered, slightly puzzled state that occurs in anxiety. There is mild clouding of consciousness and it is seen in emerging schizophrenia as new psychotic experiences are occurring. Now, morbid expressions of emotions. Here, the expressions of emotions, they are away from the normal and the patient is unaware of the emotional expressions, even though they may seem apparent to the observers. For example, in inadequacy or blunting of affect, there is complete loss of all emotional life so that the patient is indifferent to their own well-being and to that of others. For example, a patient who took visitors to the yard in his house to show them a dead dog. Now, incongruity of effect. That is the misdirection of emotions, such as an indifferent event may produce a severe emotional outburst, whereas an event that seems to be emotionally charged has no effect on the patient's emotional response. Emotional constriction, it is the most severe, in its more severe form, it is known as flattening of effect. That is, the patient displays very little emotional response, but the emotional response which is displayed is in the appropriate direction. It is seen in patients of chronic schizophrenia. For example, a patient describes paranoid delusions with very little emotions. Stiffening of effect. In this, emotional response is at first congruent, but does not alter as the situation changes. Now, next is lability of effect. Lability of effect is the speed and the ease with which a patient changes from one emotion to another. Now, normally these shifts, they are very gradual, but they can also be seen, they are normally seen in soft-hearted patients, or they can also be seen in personality disorders. Affective incontinence, that is total loss of control over emotions. There can be spontaneous outbursts of laughter or crying. It is commonly seen in cerebral atherosclerosis and multiple sclerosis. In its more severe form, the term forced laughing or forced weeping are used. The last one is morbid disorders of emotions. Now, these are regarded as pathological states. Although sometimes triggered, they can be triggered by emotional events, but they do not spontaneously resolve even after the removal of stressors, and they have their own independent momentum. In this, we'll be covering two, that is morbid depression and mania and hypomania. Morbid depression is the most common in this group. The patient would describe the depression as the way the terms would be used are like weight. They may say that they feel a weight, or there's a cloud of darkness. Morbid sadness may be associated with morbid thinking and it may even reach a delusional intensity. So the term psychomotor retardation is used when there is physical or psychological slowing and there is difficulty in making decisions due to poor concentration or due to obsessional doubting. And there may be an inner unrest, loss of confidence, anxiety, and an inability to enjoy anything in life or even get pleasure from everyday events. Now, anhedonia was a term which was coined by Ribet, a French psychologist, in 1806. It is regarded as a core symptom of depressive illness. For example, there's no joy in being hugged by one's own children or waking up to a fine spring morning, and all experiences are seen in gloomy light. Now, vital hypochondrial depression, it was coined by Schneider. Patient feels that there's a tight band around his head or a sense of oppression in the chest associated with anxiety. There may be presence of somatic features which may be attributed to physical illness rather than the psychiatric cause. Morbid depression abolishes the normal reactive changes to emotions. There's a sense of emptiness and deadness, and the patient does not feel like participating in the world anymore. There may be diurnal variation in mood. There can be loss of energy, loss of libido, anorexia, early morning awakening, initial or middle insomnia. Now, depressive stupor is a term when severe depression is clubbed with psychomotor retardation. We call it depressive stupor. Apathy in severe depression should be differentiated from apathy in schizophrenia. For example, a patient with schizophrenia does not care that the housework is left undone. But a depressive patient is able to understand its necessity, but is unable to act and experiences their failure to do so with shame and guilt. Now, morbid anxiety, it occurs in association with morbid depression. It can also present as agitation. It is seen in organic states like acute and chronic brain disease, secondary to terrifying visual hallucinations, and organic neurasthenia, which is an old term, and it is basically anxiety mixed with depression and irritability. Now, mania and hypomania. Morbid euphoria and elation classically occur in mania and hypomania, but can also be seen in organic states like hebephrenic schizophrenia, where the patient presents as silly and annoying. In mania and hypomania, elation is not related to any specific event and it is not modified by depressing influences. In mania or hypomania, we have an increased pressure of speech with prolixity. There can be flight of ideas, racing thoughts, superficial bustling activity, disinhibition, distractibility. Many projects are initiated, but none is completed. hypersexuality, or argumentative. In milder forms, the pathological nature may not be apparent, but the person may appear only cheerful. But eventually, it may lead to faulty judgment and overactivity. Often, it is only then that the pathological behavior becomes apparent. Lesions of hypothalamus may produce a clinical picture resembling mania with flight of ideas. Now, frontal lobe damage with euphoria often presents as silliness, lack of foresight, and indifference, and this term is known as moria or Witzel show. Ecstasy is an intense sense of blissfulness. The mind is occupied with feelings of communion with God or some religious figure. There may be a feeling of being in tune with the whole of nature or universe, and time may be experienced as standing still. Sometimes it is associated with grandiose delusions. For example, when a patient with schizophrenia sat smiling to himself, and when asked why, he declared that he was the king of Israel and was about to marry the queen of heaven. Ecstatic states may occur in schizophrenia, LSD misuse, epilepsy, and mass hysteria associated with religious service. My references are Fish's Clinical Psychopathology and Science.
Questions, comments, contributions? Must be answered. You understand everything? Again.
Now, this is the Yerkes-Dodson stress performance curve. So in this curve, along the y-axis, we have performance and on the x-axis, we have stress level. So a normal amount of stress is required for a healthy attention, motivation, and focused work. Now, but when now this stress, it is prolonged or it is very severe, fatigue then sets in, and then there is exhaustion, and finally there is burnout and breakdown of the person. So, and this point where this stress level from where this point of normal stress and abnormal stress, this is attributed by social support we get, or by the personality of the individual, or by the duration of the stress, or by the severity of the stress.
So what is the difference between mood, emotion, and activity? What is the emotion? Affect. All the three are related to each other. Anyone? Can you explain how the three are related?
So the definition.
Just the meaning.
So mood. So mood, it is sustained emotion. It is pervasive and it is sustained, whereas affect is what we as a doctor we infer by seeing the patient's facial expressions and the gestures and body language.
What is the difference between emotion and mood?
Sir, emotion is the state which is caused by physiological changes.
So mood is more of a background.
Yes.
It is formless. It is not linked to any object or a situation or an event. Something is locked to an object or situation or an event, that becomes an emotion. And our cross-sectional assessment of that emotion. So it's like a sea. The sea is a mood. There's some whirlwind going around is an emotion. And on the top of it, there is a boat, there's a person sitting. That is an effect. That kind of understanding. And then there are various subheadings which you need to assess effect, which can be very little confusing and pretty controversial at times. Will be assessed on all this, and then various theories as you mentioned. Any confusion with the theory? Sensation, mood effect. She got this continuation of MSc fresh psychopathology. So any confusion in this theory? Did you understand this? James Lange, Cannon Bar? No. Tanya is not understood. Just very simple term. They explain all the things.
Yes. So the first theory is the James Lange theory. Now, in this theory, for example, there's a growling dog. So according to this theory, first of all, there is physiological response to that growling dog. That is, for example, our blood pressure may rise, we'll have tachycardia, sweating will occur, and this physiological arousal will be followed by the emotion. But this theory, it was criticized that the visceral responses, they cannot be so rapid. They are, comparatively, they are slower to the rapidity of the emotion. So another theory came up, which was the Cannon-Bar theory. Now, in this theory, when we see a growling dog, first of all, there is emotion, that is fear, rather than physiological arousal, which was in the James Lange theory. So that is the difference. The third one is the Sachter-Singer's theory. So it is also known as the two-factor theory of emotion. In this, there is cognition combined with the physiological arousal that will lead to the emotion.
First is physiological emotion, second is cognition emotion, and third is combining physiological emotion. Leading to, I think third one makes sense. No questions. All the questions. I think we can go to the comments. Srinivasa, comments.
पापा आपने बात किया है इसमें आपको क्या इमोशनल एक्सप्रेशन निकलते हैं 2 दिन के बाद आपको क्या आपको नहीं तो प्राइमरी आपको बहुत गुस्सा आता है आपको खेल लेते हैं उसके बात नहीं करते हैं 2 दिन के बाद उसके बारे में समझते हैं क्यों डालते हैं आप
पापा डांटते थे सबके डांटते थे
So the emotion aspect is related to our pride in games. When the ego develops in the childhood, so that children also thinks that by हमको भी कुछ चाहिए, हमको भी कुछ अकेले चाहिए, हमको भी कुछ अकेले सीखना है. These are the things. Nobody has to touch it. If someone touching that, then the children say some anger, negative emotions. Like that. And the family, like the emotions also related to the socio-cultural context. Like emotions may be a state, may be a process. These are the things.
we give it a, our emotion is triggered by what we see the stimulus, and then our body reacts to it, and then we do emotion. In the chess theory, basically, we see the stimulus and we give it a meaning, and then our body reacts to it. And sorry, Camembert. Emotion and cognition are individual. They're independent of the situation. They can occur simultaneously. These are theories that simply give. And one more thing I just wanted to know. Affect in mania, there are levels, stages.
Yes.
Mention.
Yes, ma'am. These ma'am, euphoria, elation,
So
exalted,
if you have explained
serial. Yes, ma'am. Ma'am, euphoria is basically an exaggerated sense of well-being. There is cheerful thoughts, and the response to the depressive influence is also there. That is not there. Elation is euphoria plus increased psychomotor activity. Exalted is elation plus sense of grandiosity. And ecstasy is a sense of blissfulness, which we see in saints or religious persons.
So when we used to learn it, like in Greece, first if there is psychological well-being, right? And then with increased psychological well-being, there is increased psychological. In elation, there would be, sorry, in exaltation, there would be well-being, increased
Psychomotor
and sense of well-being. And the ecstasy is blissful. Presentation.
My professor, when I was doing MD, he had this advice for us, especially for people who are cognitively aware, that whenever you are feeling anxiety or stress, you feel that your body is tensed up. So if you want to come out of that anxiety, first, focus on your body. Like, basically like jackups to do this muscle action, but in a shorter version, like, which you can practically apply. So you used to say uncross your legs, shoulders को relax करो और facial muscles को relax करो. So that was like the special अगर आप वाइवा दे रहे हो और बहुत times do it. Okay. तो उस context में people who are aware of it, तो ऐसा करके आप अपनी anxiety को कम करो.
So you mean to say pray for tomorrow you're giving the Before coming to sir, I think presented well. Came few weeks before, and you have included both the textbooks, patients, and at times it can be little difficult to make the whole sense of the presentation, specifically these morbid emotions, expressions, make a good sense, a template in your brain. So it's little difficult and very important. I think effect is I would say very important event in a mental state examination, where most of the examiners will land up. I don't know, I've never seen anyone who has not put an emphasis on this area and has gone off. So we grilled in this very important presentation. So coming to sir. That you should assess emotions in all the patients. So when you keep on assessing patients, what happens is that, for example, you set incongruity of what the patient is saying, like describing is my delusion or insanity, but there is so much not the emotion responses, not incongruity with the what he's saying. And this happens because psychotic patient over a period of time, and we associate that this affect with the psychotic state is normal. But if you see somebody else describing a similar scene that the police is after him or his spouse is unfaithful, then that effect will be different. So you should assess effect in all the patients, even anxiety, and you see, try to see what the emotions, how they change with the person is saying. Not only assess mood in the mood disorders or say shallowness and poverty in psychotic patients, that way we tend to result. That is why in patients of mania, we take it for granted that if he's saying something that we don't attach that significance to that. So you have to match it with somebody who's not having that disorder, how his emotional state will be. Then you would be able to assess much better some amount of shallowness is always there, but we perceive it as normal because all the psychotic patients talk like that. So we think this is the way somebody is going to describe paranoid delusions. But for that person, it is reality. So you have to match the emotional state with somebody. Normally, under that circumstances, how we would be describing it. Like the whole village is after me, and that person is very scared. So that way you can make a better assessment of. Okay. So congruous with the thought process, one thing, and shallowness, that is a different. That's all. Otherwise, I think it's a very important point there because we all taken key negative symptoms schizophrenia or an undifferentiated schizophrenia or epiphania. We taken key patient will have a blunted effect or a constructed or a shallow effect. Why not sit with the patient, give them the extreme range of situations and see whether you are able to elicit it, and then probably learning it through the time rather than actually coming to an impression. Okay, yeah, that is why sir is written. This is a very important point. Why not learn from the patients? You might see not a very expansive expression of patient mania. So at times this can happen. Patient is on medications or something else. So you have to be very, very open from first way point of view and approach the cases. Psychotic state. Yes. You can have elation. You can have elation. Even without somebody like say you thought so, you can at times find psychosis also, and then you will misdiagnose. Okay. Similarly, depression, the psychotic, the psychosis is a difficult differential diagnosis because of this one. Because you are unable to differentiate whether this is, you can say, because of the psychotic state or of the depressive state. So if you are able to manage whether this is like shallow effect or it is like these exactly that you have to assess that. That you can do if you assess it every case. In all cases of depression, you should try to get whether like anhedonia. You said differentiate anhedonia is there with psychosis also. So it's not a one-off of depression. Then we end the presentation. Thank you. Thank you very much. So much. उस तरह का सिस्टम है।
Senior secondary